Hi, good morning, and welcome to the South Brunswick School Nurses interview with Dr. Richard Snepar on the COVID vaccine. We have questions for him for our faculty and staff, and we're just really grateful that he has come to do this with us a second time. Dr. Richard Snepar is an infectious disease specialist in Central New Jersey. He's been on the front lines working with COVID patients since last February in the following hospitals: Centra State, Robert Wood Johnson, New Brunswick, and St. Peter's University Hospital. Dr. Richard Snepar has been working with the infectious disease specialist for over 20 years, and he was also very helpful during the AIDS epidemic back in the 80s, 90s, when we were first presented with AIDS patients. So he has a lot of experience with the epidemic and pandemic climate. We're so grateful that you're here with us today, Dr. Snepar, and I hope that you will be able to answer most of our questions. I think you will with your expertise, and we're going to begin with Anne-Marie Kramer. Anne-Marie Kramer is the school nurse at Monmouth Junction Elementary School, and Anne-Marie, you can start with the first question.
Good morning.
Morning.
Can you please explain how this vaccine is different from vaccines known in the past? And what I'm referring to is the mRNA technology as opposed to the attenuated vaccines that we have known in the past.
Sure. Okay. So I'll go into that a little bit. So, there's the conventional vaccines which you're alluding to, which include the attenuated vaccines, and then there's these newer vaccines. So the conventional vaccines were live vaccines, right? One category was the live vaccines, and then they were attenuated. In other words, they were altered so they wouldn't cause disease or mark disease in the patient, but they would elicit an immune response. So the typical live vaccine is MMR. Or measles, mumps, rubella. That's a live vaccine. Problem with live vaccines is you can get, they're live, so they can actually cause a little bit of disease themselves. Another live, vaccine would be, the original shingles vaccine. So that's a live vaccine. Then you have a virus that you just totally inactivate. You kill it, okay? So it's a dead virus, but it's, since it's the whole thing, it's going to stimulate an immune response. So that's an inactivated vaccine. And the typical inactivated vaccine is flu. Influenza vaccine is an inactivated vaccine. I mean, there is a live flu vaccine, but we really don't use it very much. So they're all inactivated. And then you have subunit vaccines where you just have a little piece of the organism that's used, and not the whole vaccine. So it's been a piece of that organism's taken and added to a particle that stimulates an immune response. And like the pneumonia shot, Pneumovax, is a piece of the bacteria, not the whole bacteria, and that's given. Or the hepatitis A vaccine is a recombinant. But so those are the conventional vaccines. So now we're dealing with some newer vaccines, okay? We're dealing with the mRNA vaccine. And what the mRNA vaccine is that and that's, the Moderna and the Pfizer vaccines are both mRNA vaccines. So what mRNA is, okay? mRNA is a nucleic acid. It's what's utilized in the cells to produce proteins. So you have DNA, okay, and then you have mRNA, which translate different pieces of information off the DNA. So they take this piece of mRNA, which can code for the spike protein of coronavirus, which is what attaches to the cell. And they take that mRNA and they wrap a little piece of fat particle, a nanoparticle into it, around it. Okay, and they inject it into your skin, and the mRNA gets incorporated into the cell, and the cell sees this mRNA. The mRNA never goes into the nucleus of the cell. It doesn't have anything else other than the mRNA. It can't be incorporated into the cell. So, but it codes for the spike protein, and then the mRNA is destroyed. These proteins are elaborated by the cell, the spike, and then you make antibodies to it, and that's your immune response.
SARS-CoV-2 is a novel coronavirus that is responsible for the COVID-19 infection. The virus works by entering healthy human cells through the crown-shaped protein spikes on its surface. A promising candidate for the treatment of COVID-19 is a messenger RNA-based vaccine from Moderna Medical. Messenger RNA, or mRNA, are strands of genetic material similar to DNA that ribosomes in the cell use to synthesize proteins. Moderna's mRNA vaccine contains the instructions to synthesize the crown-shaped protein spikes on the surface of the SARS-CoV-2 virus. The vaccine is encapsulated into a lipid layer that allows it to enter the cell. Once inside the cell, the mRNA are released and ribosomes in the cell read them to synthesize the virus's spike proteins, which are then released from the cell. The spikes themselves are not harmful, but the human immune system perceives them as though the body has been infected with COVID-19. In response, the immune system produces antibodies against the SARS-CoV-2 virus. In the presence of an actual COVID-19 infection, these antibodies prevent the virus from entering a healthy cell by attaching themselves onto the spike proteins, thereby blocking their entry into the healthy cell and thus creating immunity.
And that's your mRNA vaccine. That's the Pfizer vaccine and the Moderna vaccine. The J&J vaccine is not an mRNA vaccine. That is a vectored vaccine is what we call it. And so they take a virus that's inactivated, they put a particle of that RNA in there, and they shoot the virus into the body. And that virus itself, it's an inactivated virus, infects cells, releases the mRNA, and then creates new virus and creates an immune response.
Great. All right, thank you for that. Next, we're going to Susie Hansen. Susie is the nurse at Brunswick Acres Elementary School.
Hi, Dr. Snepar. I have a couple questions about the Moderna and the Pfizer vaccines. What is the level of immunity you receive after the first vaccination? And do they know about long-term immunity yet? Or will we need to receive this vaccination seasonally like the flu vaccine?
Your immune response occurs relatively quickly after the first dose. If you look at the placebo patients versus the patients that receive the vaccine, the curves start to separate at about 10 days. And you start to see an immune response in the vaccinated patients. Now, it's not a complete immune response. And if you look at around in the first 2 weeks, there was about a 50% protection rate. And then once you get that second vaccine, about 7 days after the second dose, you're reaching the maximum level of efficacy of that vaccine, which is, 95% immunity. Now, in terms of long-term immunity, how long that immunity is going to last, it's not clear. There was a recent posting about the Moderna vaccine that immunity looks like it's going to last. It could last at least a year, and how good that immunity is going to be also is now going to depend on what's going to happen with variants and other manifestations of this virus. But it looks like it may be lasting at least a year.
Wonderful. Okay. Thank you for that. And the next person that we have is your lovely wife, Barbara Snepar, who is Crossroads North Middle School nurse.
Hello from the dining room. So Rick, you've actually answered a couple of my questions, but I do have another question for you because the vaccine rollout has been, rather disorganized in New Jersey and elsewhere with shortages and people getting turned away. I'm just wondering if you could explain a little bit about mixing the vaccines. So for instance, can you get a Pfizer vaccine and then the Moderna vaccine?
Okay, so the official recommendation as of the 23rd of January is that you are not to mix vaccines, if at all possible. They just should not be mixed. Now, if you have a situation where you cannot determine in the vaccinee what vaccine they got, and just doesn't recall, just can't get the records, just has no idea what vaccine they got, then at that point you can give them whatever vaccine, whatever mRNA vaccine you have, and it should be given at 28 days or more, just figuring that it was the longer interval vaccine. Because one of the things you don't want to do is give the vaccine on the shorter end. It's always better to give it on the longer end.
And then the second part of my question is, at what point after the second vaccine are you free and clear? Are you safe? Do you have your full immunity and can feel really good about going to a concert or going to anywhere, just back to your life?
So that's like the big question. So in the Pfizer study, which is where we're basing these things on studies. In the Pfizer study, the endpoint was no clinical disease at 7 days after the second dose. Okay, so that's where they looked at it. That's where that efficacy number was at. And that efficacy number is at 95%, 94% over the age of 65. Moderna vaccine was 14 days after the second dose with a 94% efficacy, efficacy of the vaccine and 100% in people over the age of 75, which is really incredible. So we only know to go by the studies, but so it's 14 days, you should have, looking at that vaccine, you're going to have 94% efficacy. Now, there's two issues. One is, and that goes into another question. One is, well, that's your own protection. Now, does that allow you to resume normal functioning? That, I guess that remains to be seen, but it can be thought about. They just this morning I was reading in the New York Times, Israel, which has been very proactive, and they've been working with Pfizer to get a large percent of their population vaccinated, and they had like in 500,000 cases, 450,000 cases of vaccinees. There were like an incredibly low number of cases of actual illness. It was like 0.015% infected people. So, I mean, it looks strong. It looks like there's going to be good immunity, and that will allow people to get back into society.
Mm-hmm. Great. Yep. All right, next we have Nurse Rena Eng, and she is from South Brunswick High School.
Good morning, Dr. Snepar. I have a couple of questions. My first one is, there's been a lot of talk in the news that they may not give the second dose. They're going to give everybody a first dose and then hope that more supplies come in. So if we don't get the second dose on time, what is going to be the immune response? My second question is, and it's a follow-up to what Barbara said, is when can we take our masks off? I have friends calling me assuming that once they get their 2 doses, they can take their masks off, and I'm telling them, no, they cannot. Mm-hmm. My third question is, if we got contracted COVID after being vaccinated, can we assume that our response would be much less severe than had we not had the vaccines? Thank you.
Okay, so the first question is, repeat that. Can you just, so I can go in order? The first question was? Is
if we don't get the second dose on time, if they delay that.
Right, so if you can't get the second dose on time, what they're saying is that you can really safely wait up into 6 weeks to get the second dose with an adequate immune response, and probably longer than that. with some of the recommendations, as we'll get into, with people who have gotten COVID and then got the antibody, and then, we're really going to have to wait actually, 90 days to get their second vaccine. But so it looks like you can wait at least 6 weeks and still get a second dose. You can't get a second dose early, but you can get it late. The next question was that regarding masks?
Yeah, when can we be free of our masks?
Okay, so it's two issues. One is protection.
Right.
Okay, so the vaccine gives one protection against illness, right? And the other issue was transmission. Okay, and that's the mask. Okay, is the mask gonna? The mask prevents transmission. Is the vaccine going to prevent transmission? That's something we really would like to know. Besides preventing disease, is it going to prevent transmission? That data is not out yet. There is a little bit of data out in the Moderna group where they looked at a small group of their 30,000 patients, and they looked to see if over the 4 weeks after vaccination, they checked PCRs, and they wanted to see if their nasal PCR turned positive. Because, if it stays negative, well, then you have really a good feeling that you're not going to transmit. You're not going to have any evidence of virus. So, and it was a very small number. So 14 patients in the vaccination group had a positive PCR. And 38 patients, they only looked at 52 patients, 38 patients in the placebo group developed a positive PCR. So it was 3 times as many from one group to the next. So transmission is still, the jury on transmission is still out. And it's a very important piece. And I think over the next few months, we're going to be able to see what happens in terms of transmission. But for now, you really need to wear your mask.
Mm-hmm. Yeah.
So,
and Dr. Fauci just said last night on the news, maybe we need to wear 2. So that just came out. So, okay, next we have Janice Royer, who is a nurse at Crossroads South.
Good morning, Dr. Snepar, and thank you for taking our questions this morning. If I should become positive for COVID after receiving my first vaccine, but before I receive my second, what should I be doing at home to self-monitor my condition? And when should I go to the emergency room?
Okay, so yeah, we're seeing a little bit of that actually. So if you get your first vaccine and then you start to get, you say you've been now diagnosed with COVID. You've been diagnosed with COVID. You have to act like you would even if you didn't have the vaccine. You would monitor yourself in the same fashion, and that's, I think, the most important thing to monitor is are your vital signs actually, and those are your respirations, your ability to pulse, your ability to walk and ambulate, without getting clinically short of breath. Number one, and then I would also, as I've mentioned before, objectively monitor your pulse ox. And, as long as you can defend your pulse ox up to 95% or more, you're okay. We're hoping that even if you get, the disease after vaccination, it will, lessen the hit of the disease. But again, it all depends on how early after vaccination you're going to be, picking the disease up. Where in the disease are you? But severe COVID. The definition of severe COVID is a pulse ox of 94% or less. So you want to monitor your pulse ox, monitor your heart rate. If you're getting shortness of breath on exertion, that's something you need to seek attention for. And that's my feeling is that you need to go to the ER for that. You can't take that lightly. That's what you would monitor. Also, there may still be a role for getting the monoclonal antibody, even if you get you would treat it just like as if you had COVID without the vaccine. there's a role, there may be a role to get the monoclonal antibody. But that can be also, that whole entity can be argued as well.
Mm-hmm. And just to let everybody know that you can get pulse ox at every drugstore, Walgreens. They're battery operated. You just put it on your fingernail. They're pretty direct. So recommended that if you do have a family member with COVID, that you would purchase a pulse oximeter so that you can monitor your family member's pulse ox, get a base rate, and then see if it goes down. Next, we have Jill Kerwin, and Jill is nurse at Cambridge Elementary.
Thanks, Donna and Dr. Snepar, for doing this with us today. My question related to what are the side effects of the vaccine that we can expect after the first and the second vaccine. And I have heard that some of them can be pretty severe. So how do we determine whether we are having side effects from the vaccine or whether the symptoms that we're experiencing could be COVID related?
Okay, so you got local side effects and systemic side effects. So the local side effects, number one would be, as anybody who's got a vaccine would tell you, is pain. That's the big side effect, and I'd say it's up to 85% of the people had pain at the injection site. Now I was thinking, well, yeah, you get pain from the vaccine. Sure, you're getting a shot in your arm. It's going to hurt no matter what they gave you. But the placebo group actually didn't get that much pain. Only about 15% in the placebo group got pain. So that's a local effect. And then the second big local effect is redness. And a large proportion of patients get redness, which tends to goes away quickly. It goes away, and actually, it should go away in a day or two. Then you get the systemic side effects, and the big systemic side effects are fatigue, headache, and body aches. And they were seen in a fair proportion of patients as well. With the Pfizer vaccine, it looks like the duration of side effects of those side effects lasts about a day. With the Moderna vaccine, it looked like their side effects lasted up to 2 to 3 days, but they're short-lived. So if you're looking for that versus COVID, if you're looking at that versus COVID, these symptoms are going to go away. COVID symptoms are going to be more persistent. Fever is also pretty significant, especially with the second vaccine. Up to 20, it looks like about 25% of patients or so are going to get fever after that second vaccine. Some lesser amount after the first vaccine. Again, that should go away relatively quickly. So if your symptoms are lasting more than 2 days, then you got to think, well, maybe it's, it is something else. It's not just the vaccine. Now I can see that first day being a little nerve-wracking because you're not quite sure what you got. But, we're seeing a lot, these vaccine reactions, and they are coming and then they are just going. A couple other side effects to just note, lymphadenopathy on the side of the vaccine has been seen with both vaccines, and that goes away in a couple of days. And then there's there were about 4 cases in each group of Bell's palsy, but they looked, apparently the Bell's palsy incidence in that population group was the same as in the normal population, but it's been talked about.
All right, great. Thanks, Rick. And the next person we have is Sunis from Brooks Crossing Elementary.
Good morning. Do you feel that the current medical treatments of your patients with COVID are improving their outcome with the new medications that you're giving them? Or is it more timely, like if they get there early on?
Right. So no, I think it's a combination of both. I think it's very important to get to the hospital or get attention early, especially if you're starting to have signs that the illness is taking the wrong turn, where your oxygen levels are dropping. So that's important. But I think the medications that we're using are having a positive effect. Early on, back in the spring, we were really unclear, when to use steroids. Should we use them? Should we use them late, early? It was not known. Now we're using Decadron right up front. It seems to make a very a big difference in patients with, patients with hypoxia, with a saturation that's 94% or below. Also, the use of remdesivir now seems to be making a difference, especially when you're getting patients before they're really sick. So the combination of remdesivir, Decadron is important. The concern of clotting as a factor in COVID is a big one, and we're learning how to better anticoagulate patients as we go along to prevent them from getting side effects of pulmonary emboli, stroke, things like that. So that's coming along, and that's actually it's morphing as just day to day in terms of that, all of that information. So I think, respiratory support has changed, being supporting patients without the use of ventilation in better ways. That's also been very helpful. So yeah, I think we're making progress in therapy.
Great, thanks. And the next person we have is Bin Guo from the high school.
Good morning, Dr. Snepar.
Good morning.
My question is, so many people can't, get the COVID-19, and for people who recover from COVID, shall they get the vaccine? And if so, how long they need to wait to get it after they recover? Is there a time frame for them? Yeah.
Okay, so people who recover from COVID, who get COVID vaccine. So the recommendation is actually you can be vaccinated from COVID vaccine. That's not a contraindication to vaccination. Actually, it's encouraged to vaccinate somebody after they have COVID vaccine, and you can be vaccinated as soon as you come out of isolation. So so you can take that vaccine. Now, it's also said that the immunity from the illness of COVID-19 will last at least 90 days. So one could wait for about 3 months before the necessity of getting vaccinated. And so there's not a rush, especially if vaccines are hard to get. So you could wait 90 days, but any time within those 90 days too, you could be vaccinated.
Okay, and the last question is me. I'm Donna Sickter from Indian Fields Elementary School. And I actually got a text from a teacher who was concerned about getting the COVID vaccine. And with that, perhaps having carrier status at some point in between the two vaccines, bringing COVID home to her family as a result of being vaccinated. And I wanted to know if you could just explain why that wouldn't happen. Thanks.
Right. So as we said earlier, the vaccine is a piece of RNA. It's just a small few amino acids. It's not the virus. Okay, it's a protein of the virus. It's not going to. It's going to be placed into the cell to mimic to facilitate the growth of another protein of the virus, so you can form antibodies to it. So there's no whole virus. There's no mechanisms in that RNA to reconstruct the whole virus, and the mRNA is actually injected into the cytoplasm of the cell, not the nucleus of the cell, where all the genetic machinery is. So it's not even going to get into the nucleus of the cell. It can't. And that piece of mRNA is one of 20,000 other mRNAs in the cytoplasm. mRNAs are making protein all the time, and it's also destroyed after a short while, that piece of mRNA by your enzyme. So it's there, causes you to make antibodies and then it's gone. So there's no virus there.
Actually, I did forget one person. I've got Donna Maureen here from the high school who'd like to ask you a question as well.
Sure.
Hi, Dr. Snepar. Thank you
Hi.
for doing this for us. I have two questions. One is, why weren't we able to develop the SARS-CoV-1 vaccine, but we were able to develop the SARS-CoV-2 vaccine when they were such similar viruses, is the first question. And second question is, do you believe that COVID-19 vaccines should be made mandatory for schools?
Well, SARS-CoV-1, they started the technology, they started to develop it, and then it was just not really pursued. And I suspect because the original SARS epidemic was self-limited, it wasn't as big, and it was well contained. It wasn't a worldwide. It wasn't a pandemic at that point. So I think the push fell off. They were able to develop. They made progress towards developing an Ebola vaccine. That needed to be done. But I think there was a big push to get this, as you've seen, to get this vaccine out to interrupt this transmission. Should the school be vaccinated? Well, certainly teachers should. I think they all should be vaccinated. And now whether this vaccine is going to be approved for children, that remains to be seen. There are trials going on right now, but the Pfizer vaccine is for 16 and older, and the Moderna vaccine is for 18 and older. But yeah, I think teachers should be protected. They should be right up there getting vaccinated, especially if you want to get back. And if approved, we'll see what we need to do with the kids.
So just a follow-up question. So what happened with the SARS-CoV-1? How did that one disappear, but this one didn't when they're so similar?
The facility of transmission was less on COVID-1. It wasn't as easily transmissible. It was much more deadly. And that may also have made it less transmissible, because if you weren't going to get the illness and then go to the movies, there wasn't a big asymptomatic phase. There wasn't a big population getting. You got COVID-1. It was bad. It was you look like the hospitalized patients of COVID-2, but that's who was there. That's what you got. I think it was it's over 50% mortality rate.
Okay. Thank you.
So, Dr. Snepar, we have heard that Johnson & Johnson, their vaccine is in the warehouses and really ready to roll out, but the holdup is the FDA. So, do you have any inside information from specialists when Johnson & Johnson will be released to the public, or when they anticipate the FDA approval?
The word is, as I guess we've all heard, is that in the next couple of weeks, we should be hearing information regarding the emergency use authorization of the J&J vaccine. The data is not out yet, or it's not been available. What's its efficacy rate? Is it comparable to this? That's not out. So, that's what we're waiting to come out. If that comes out and looks like Pfizer and Moderna, great. And I guess nobody's saying that it's not like that, and I'm hoping it will be. But there's nowhere to find information on that.
One last thing, if you could speak to, and I don't know if you touched on this yet, but the importance of using BAM for people that are starting to go south at home, if you see a relative, and its availability in our local emergency rooms now, because you really helped me with a severely ill friend on that recommendation, and she turned around in 24 hours.
Right. So in the patient with mild COVID or newly diagnosed COVID in the first under 10 days, patients having relatively minimal symptoms, the use of a monoclonal antibody can stave off more severe disease. So there's two antibodies, there's bamlanivimab, and there's the Regeneron product, which is a combination of that drug and another antibody that are given, and they're available in the emergency room. And you need to be COVID positive with minimal symptoms of recent diagnosis. So you need to know that you can go over to the be sent to the emergency room. You need to have a positive COVID test, and you could be given these antibodies. Now, since the last time I talked to you about this, just this week, a study came out looking at bamlanivimab alone and the combination Regeneron product. And the Regeneron product looked much better than the single antibody. Basically, we've been sending people over to the ER and asking to get just, whatever they have. But it looks like the Regeneron product may be a little better. But I think it's an important adjunct right now in terms of, our therapeutic armamentarium.
So I guess the bottom line for that is that the emergency room is probably the last place anybody wants to be or is avoiding with COVID. But if you're turning south with COVID at home and your pulse ox is dropping, the best thing is to go to these local emergency rooms where these options of therapeutics and antibodies are there to completely turn around the course of COVID, right?
Right. As with any illness, early treatment and early diagnosis and treatment is key, just like anything. And you don't want to wait. Now you don't want to go in early, they'll send you out, but you want, if you want to monitor the patient, keep an eye on their vital signs. And if it looks like they're heading in the wrong direction, and you can't be too far in that wrong direction. Many patients of ours in the hospital that get into trouble, they're coming in they're waiting till their pulse ox goes down to 88. You'll have somebody coming in at 70. When they're coming in at 70, their chance of getting out is extremely unlikely. But if they're coming in at 94, 93, some remdesivir and Decadron, in a few days they'll be good.
Mm-hmm. Great.
So,
okay, ladies, if you have any other follow-up questions to anything that you heard today, just unmute and ask the question. Otherwise, I just wanted to thank Dr. Snepar so much for coming in and answering a lot of questions that I think our faculty and staff have, and will clear up the information and at least help enlighten them a little bit about the various vaccines, what's available, and side effects, etc. So thank you so much, Dr. Snepar. We're all giving you a round of applause, and we're so grateful that you came to be with us today. So thank you.
Sure, it's always a pleasure. Just let me know when I can help you out again.